This is the last of 4 modules, the Model for Improvement. This module will introduce you to the methodological elements of the Model for Improvement and provide opportunities to apply each element to your QI opportunity. You will find it helpful to follow along in your workbook with the module, to take notes and participate in the interactive application sessions. There are 7 learning objectives for this session. After this session, you will be better prepared to answer the 3 fundamental questions in the Model for Improvement, which helps you structure your improvement plans. Those 3 fundamental questions also help you focus your quality initiative. We will introduce the use of a project charter to document your project efforts, and you will learn the steps in the development of a problem statement that describes the reason for the effort for your improvement initiative. You will be able to establish an aim statement, which will describe positive change and is SMART. You will be able to define measures for improvement and recognize the difference between outcome measures, process measures, and balance measures. You will be able to construct a driver diagram to describe the relationship of your QI project to broader organizational quality improvement activity. And you will be able to use change concepts to develop specific change ideas you can test. This is the Model for Improvement. It was developed by a group of biostatisticians and engineers who worked with Dr. Deming, the guru of quality improvement. All of these authors are faculty with the Institute for Healthcare Improvement, or IHI. The model asks 3 questions. What are we trying to accomplish? The aim. How will we know that a change is an improvement? Measures. What change can we make that will result in improvement? Change ideas. The change ideas that we generate as QI teams are tested using the PDSA, Plan, Do, Study, Act cycle. Your clinical team has completed and prioritized an improvement inventory that will guide you to an improvement opportunity and project idea. Next, you will develop a problem statement that leads to the development of the aim for your project, specifying what it is you want to accomplish. Note, as per this visual, that during the course of your project you will identify many change ideas, select a handful to test, and conduct many PDSA cycles with each change idea. A charter is a written constitution or description of an organization's functions. It also serves as your QI team's commitment to a blueprint as to how to structure its improvement efforts. Charters in QI work are meant to be working documents with an iterative nature, meaning you will come back to this document many times to change various elements of your project. Ultimately, the charter serves as an important communication tool surrounding your project for your team and beyond. As we go through this module, focus on the opportunity for improvement that you prioritized after reviewing perceived and unperceived needs and reflecting on feasibility and impact. Write down the opportunity for improvement or the QI project idea that you selected in your improvement opportunity work. To develop a charter for your QI project, think about your proposed team members and their roles. An important element of the charter is the problem statement. The problem statement addresses many elements that ultimately assist in justifying the reason for the improvement effort in a particular area. A problem statement answers the questions: what is the problem you wish to address? Why is it a problem? Where do we observe the problem? Who is impacted? When? Is it ongoing or recurrent? Which of the quality dimensions are involved? Let's look at an example of the development of a problem statement. What? No-shows. Patients with appointments who fail to attend without canceling. Why is this a problem? Problem statement, example. Why? Disrupts stable patient flow during clinic. Limits appointment availability for others in need. Uncertainty introduced into patient's healthcare need. How do we follow up to ensure patient does not still need a visit? Lack of knowledge as to root cause. Note that we may need to do some data collection, qualitative and quantitative, to be able to answer this. Where does this problem occur? Greater problem in residence clinics as populations seen often less attached. Who is affected? Patients, those who fail to attend and possibly lack follow-up, and those who lack access to an appointment not kept. Staff, hard to allocate staff resources, reception, additional phone calls to follow-up. Physicians, hard to decide what to do, wait, work on another task, etc. When does this problem occur? Occurs regularly in residence clinics, much less commonly with staff MDs, nurses, and allied professionals. Can you identify which quality dimensions are at play? Access, efficiency, patient-centered, effectiveness, equity. Here's an example of a problem statement that has been developed in follow-up to answering each of the questions. Problem statement example. Our problem is the number of appointments not kept, particularly for residence schedules. This disrupts the normal flow of patients, creates uncertainty in the need for follow-up, makes it difficult to assign time and resources, and limits appointments for others in need. We are uncertain where to assign cause, with patients or with our systems for appointment booking and follow-up. For this and the exercises that you will note in the remainder of this module, please refer to your workbook for note-taking. You may wish to pause the video so you can reflect on the direction and complete the exercise. This exercise is focused on the creation of a problem statement that relates to your improvement opportunity or project idea. Create a brief problem statement. Reflect on the statement and how it describes the problem that is behind your QI project idea of opportunity for improvement. Did the creation of a problem statement assist you to think differently about the opportunity? For this section of the module, we are focused on the first question of the model for improvement. We will be specifying and setting an aim for your improvement opportunity or project idea. When we specify and set the aim, we often refer to beginning with the end in mind and think about what does good look like. This is your aim statement. When you describe what you are trying to accomplish, consider best practices as defined by the evidence from the medical literature. Consider best practices as refined by the expertise of people you respect. Consider best practices refined again by the reality of your practice setting and peers from different practices. It is important to use multiple, complementary sources to benchmark your practice. Setting the aim of your quality initiative defines the goal. The aim statement asks the following questions. What system is to be improved? Who is the population of focus? What is expected to happen? What is the time frame? And what is the goal? SMART aim statements are articulate descriptions of what you're aiming to improve. They are specific, measurable, attainable, relevant, and time-bound. One way to learn how to develop a SMART aim statement is to review some examples. Here's an aim statement. 60% of adults diagnosed with diabetes will achieve targeted blood pressures of less than 130/80 within 12 months. It's specific, adults with diabetes. It's measurable, I'm aiming for 60%. It's attainable, I think I can do this within my practice. It's relevant, an evidence-based best practice for blood pressure targets for patients with diabetes. And it's time-bound, within 12 months. Let's work through a second example. 75% of patients will be seen by a healthcare provider within 5 minutes of a scheduled appointment, within 3 months. Specific, we're talking about patients. Measurable, I'm aiming for 75%, not an unrealistic 100%. Attainable, my team can do that. Relevant, we're describing something that's really relevant. We can do this at our practice. And time-bound, we're giving ourselves 3 months to work out the kinks. You can be even more informative about your intention if you can incorporate present and future states into your aim statement. Here is the aim statement from our case study. In this instance, the practice intentions are specific. Define the population and set a timeline, all of which they believe to be attainable and relevant. Reflecting on your QI opportunity, take the time to develop a SMART aim statement: specific, measurable, attainable, relevant, and time-bound. You may wish to pause the video so you can reflect on the direction and complete the exercise. This exercise is focused on development of an aim statement that relates to your improvement opportunity or project idea. Once you have developed your aim statement, reflect on it. Was it challenging to develop the aim? Was any feature of the aim statement trumping other features? Sometimes teams find that relevance and time-bound are the most challenging features to include in their aim statements because of the variation in team member perception about a particular opportunity. When reflecting on measurement in QI, it is helpful to compare and contrast with other measurement foci, such as measurement for research and measurement for accountability. Reviewing each element, let's read across to compare and contrast measurement in QI from measurement for research or accountability and comparison. Purpose: for learning and process improvement, it is to bring new knowledge into daily practice. For research, it is to discover new knowledge. For accountability or comparison, it is comparison, for choice or to provide reassurance and spur for change. You can review the remainder of these measurement facets at your own pace. It is important to note that each of these measurement perspectives plays a critical and important role in healthcare. They are just different from one another. When we reflect on measurement in QI work, we are reminded that we are measuring aspects of a system. Because a system is an interdependent group of items, people, or processes working together toward a common purpose, and because healthcare systems are complex, adaptive systems, we require a family of measures, which includes outcome, process, and balancing measures, and follow measures frequently and continually while we improve through many tests of change. Outcome measures look at the results of a process. They reflect how a system is working. For example, what is the rate of adverse medication events? Outcome measures answer the question, are we fulfilling our aim, and are considered the so what piece as related to the aim, and in many cases reflect what is important to patients. Examples: safety, adverse events post-hospitalization; access, seeing their preferred primary provider when sick; patient-centered, perceived ability of primary provider to hear and understand patients' problems. Process measures are measures of a high-level activity that provides a service. You can measure whether a process or an activity has been completed. You can measure parts of a system. An example is recording the time that a patient waits to see a provider. That's a process measure because what you're measuring is a process or a step in the system of patient flow. Process measures, sometimes referred to as the voice of the process, and reflects how steps in the system are performing. Answer the question, are we doing the things we thought would result in an improvement? May not be as important from the patient's point of view compared to the desired outcome. Examples: safety, time to first follow-up appointment post-discharge; access, number of same-day appointments available at the start of the day; patient-centered, red zone time, percentage of visit cycle time that patient spends with provider. Balance measures help ensure that improvement in one part of a process doesn't impact, negatively or positively, something else. They ask if we are inadvertently having a negative impact on other parts of the system, or what could go wrong if we do this. A common balance measure in healthcare QI relates to the impact on a team member of a particular change. For example, if I am able to improve access to a primary care provider, Is there a negative impact on the staff workload or a positive impact on no-show rates? Safety, unnecessary appointments. Access, increase in variation of volume of appointments per day. Patient-centered, leaving later in the day. It is helpful to see if your measures align and can describe different system perspectives. For example, if we improve safety, we anticipate seeing a decrease in adverse events post-hospitalization. We measure those events as a rate of or number of as outcome measures. The process measure is the time to first follow-up appointment post-discharge. Access to care is positively correlated to lower adverse events. If patients can access care when they need to after discharge from hospital, there are likely to be less adverse events because issues or concerns can be addressed in a timely manner and in some cases avoided altogether. The balance measure accounts for unnecessary appointments. How many patients come to the clinic post-discharge for follow-up but have no concerns? Should we follow up for the sake of following up or because there is a risk? A common measurement in Ontario is 7-day follow-up appointment with primary care post-discharge from hospital. Many teams that have worked with this measure have identified that not all patients need to be seen within the 7-day window. Sometimes an outreach call from a primary care team is all that is required to ensure recovery is on track. Review the 2 remaining examples on your own, reflecting on the alignment of the outcome to process to balance measure. There are many systems in primary care and hence many measures, often of interest to governments. Examples are clinical measures, including screening for cancer, health promotion through vaccinations, acute care, antibiotic use, clinical measures including screening, cancer, health promotion, vaccination, acute care, antibiotic use, chronic disease, effectiveness measures such as hemoglobin A1C, end-of-life care, pain scores. There are also administrative systems and examples including scheduling, same-day access, patient flow, cycle and wait times, billing, efficiency, rejected claims. Admission rates is a reflection of the interaction between primary and hospital care, the day post-discharge measure. Now it's time to evaluate and identify measures for your quality initiative. Once again, you may wish to pause the video so you can reflect on the direction and complete the exercise. This exercise is focused on identifying measures for your QI project. For your aim statement, what are some process measures, outcome measures, and balance measures that you may employ? Challenge yourself to identify at least one of each measure for your improvement opportunity to project idea. Most QI projects are able to identify process measures more easily than outcome measures, so this may be your experience too. Remember to make sure the measures align to your aim statement. Driver diagrams are useful in QI work as they describe the relationship between aims, measures, and change ideas by thinking of them as respective drivers. When we view content on a driver diagram, we are viewing the perceived causality between aims, primary drivers, and secondary drivers. All your resident QI projects will be in the secondary driver category. However, it is helpful to see where your project fits relative to broader organizational QI work. Driver diagrams create a logic model that develops and communicates an approach to achieving an aim. It identifies hypothesized relationships between primary and secondary drivers of change. Note that driver diagrams may use aim, primary, and secondary, even tertiary drivers, or aim, measures, and change packages, which include change ideas. Some driver diagrams include both for additional detail. Driver diagrams are often a rich visual of the complexity of the many factors or drivers that relate to a particular QI project. Here is a simple, maybe not if it's you trying to lose the weight or support a patient to improve their health, example of a driver diagram used to describe the relationships between secondary drivers, example, reduce amount of food, primary drivers, example, reduce caloric intake, and the aim, losing weight. Please view the IHI YouTube video shared by Dr. Don Goldman at your leisure. As an example of a driver diagram application, this aim relates to the 100,000 Lives campaign that IHI initiated in 2004 at their annual forum. Note the 6 practices that are listed on the left. These are evidence-based practices, incorporating many change ideas that IHI recommended teams implement via a QI approach. For many teams, implementing even one of these practices was a considerable endeavor. To illustrate the relationship of these practices to the overall aim of reducing lives lost, development of a driver diagram describes the relationship between these practices and the specific change packages or bundles that respective teams focused on. In this driver diagram example, the practices that are listed on the bottom of the previous slide are included as primary drivers. Achieving improvement in one or more of these drivers positively influences the goal of 100,000 lives saved. It is challenging for teams to work at the level of primary drivers without more detail because our healthcare systems are so complex. So, the secondary driver related to one of the practices, prevent surgical line infections, is noted in the blue box. Collectively, these secondary drivers are a change package. However, each one could be a small QI project for a team. In this example, the driver diagram describes the relationship between a change idea, hand hygiene, specifically its relative improvement, and surgical line infections, leading to lives saved. In this example of a driver diagram for COPD, the red star on the right of the slide highlights a change idea or a small QI project, patient information leaflet. Looking left, the next red star highlights the secondary driver, education of patient on their condition and management plan. The next red star highlights the primary driver, appropriate provision of clinical care. This driver diagram illustrates the relationships between the aim to improve quality of care for COPD patients, the primary drivers, and secondary drivers with specific detail around some of the change ideas. The contribution that a patient information leaflet can potentially make to improving education, or secondary driver, and improving appropriate provision of clinical care, primary driver, is therefore described visually relative to the aim of improved quality of care for COPD. The third question in the model for improvement asks us to identify the changes we can make that will result in an improvement. To identify changes that we believe will lead to improvement, we may reflect on our practices, brainstorm as a team, use change concepts to develop change ideas. Recall from the Module 2 on system diagnostics that we can also use tools such as the cause and effect diagram to assist us in identifying change ideas that are likely to be impactful. Change can be either reactive or fundamental. Reactive change keeps a system running. Reactive change is a response to an immediate problem. Reactive change usually has only short-term impact. Reactive change is not QI. An example of a reactive change is hiring someone to call patients to come in for a screening test. The next slide will comment on how to frame change so that it is fundamentally different. Hiring people to perform tasks versus redesigning systems to support processes like screening is usually not sustainable from a funding or human resources perspective. Fundamental change, on the other hand, essentially alters an activity. Fundamental changes are necessary to prevent problems, rather than responding to them as they arise. Fundamental changes have lasting impact. Fundamental changes are quality improvement, a fundamental way of permanently improving primary health care. An example is using electronic reminder systems in the EMR to improve screening rates. The number one source of change ideas is your QI team, but you can also generate change ideas from your system diagnostic tools, such as cause and effect diagrams, brainstorming, and benchmarking against evidence-informed practice, clinical practice, and medical literature. Change concepts are another source for change ideas that we will discuss in greater detail in a subsequent slide. There are many sources of change ideas. Use the output from the system diagnostic tools your team has used. Learn from knowledge experts, people you respect, mentors, really good doctors. Think logically and analyze current practice procedures. Think creatively and use technology appropriately. Copy, replicate, duplicate others' good ideas. Most importantly, be open to testing change ideas. Impact is sometimes hard to predict until you test. In your workbook, there is a list taken from the Improvement Guide Appendix A that includes over 70 change concepts. These concepts are approaches to change that have been shown to generate change ideas. Using change concepts can elicit specific change ideas for your QI initiative. Let's look at some examples of change concepts. One change concept is to eliminate waste. Study your process for duplication of effort. Find and remove bottlenecks. Ask yourself if there is one step slowing the entire process. Improve workflow. Can you find efficiencies by changing who does what and when it is done? Use technology. Would technological applications improve the overall efficiency of the process? Standardize. Can you identify unnecessary variation? Force function. How can we make the right thing to do the easiest and possibly the safest? You may wish to pause the video so you can reflect on the direction and complete the exercise. This exercise is focused on generating change ideas for your improvement project. While it is not always easy to generate a large number of change ideas on your own, see how many you can generate for your QI opportunity. It is sometimes helpful to give yourself a time window within which to do this. For example, 10 minutes, and to stretch your mind beyond the changes or solutions that you feel will lead to improvement. Document all the change ideas you can think of in your workbook. Now we are ready to test the change ideas that we generated as a team as part of the third question in the model for improvement. The PDSA, Plan, Do, Study, Act, Cycle, is the testing approach we take with each change idea. Note that there are many PDSA ramps in this visual of the model for improvement. For each change idea that we decide to test, we can anticipate a number of PDSA cycles or tests of change. Because our healthcare systems are complex, we rarely test once and are ready to implement a change. We often need to test repeatedly in an iterative fashion to learn about the effectiveness and impact of a particular change. To facilitate learning about the PDSA cycle, please refer to the PDSA worksheet in your workbook. This is one version of a PDSA form that supports you to lead a team through the PDSA cycle. The form documents your progress as your team tests each change step by step. Plan, do, study, act. This is something you will use throughout the Quality Improvement Initiative to track your change idea testing. This form will be available to you electronically so that you can adapt and edit it to meet the needs of your project. As we go through the remaining parts of the module, follow along on the form, which will support your learning. PDSA Worksheet. Plan. Describe the following: objective of the cycle in details, data to be collected, who, what, when, where, predictions and questions. Do. Carry out the change or test. Document problems and unexpected observations. Study. Complete the analysis of the data. Compare the data to your predictions and summarize the learning. Act. What changes need to be made? Plan for the next cycle. The first step in the PDSA rapid cycle for improvement is plan. This is when you state the purpose of the test. You predict what you think will happen, and select a measure as feedback in terms of the effectiveness of the test. The measure may be quantitative or qualitative, and as simple as a number. For example, output of something, or a yes-no answer. For example, was a form easy to use? Prediction is a critical element of the plan phase, as it drives the learning about our systems. We predict as we would hypothesize. We measure to determine if we are correct in our prediction. The next step is do. You prepare to do by detailing the actions and tasks of your test. Then you go ahead and conduct the test, collecting the data for your test of change measure. Then you're going to study the results of the test of change. Analyze the results of what happened, the test, the data you collected during the test, and compare that to what you thought might happen, your prediction. This is a critical piece of the PDSA cycle, linking back to Dr. Deming's Building Knowledge. This is where we learn about our system. What do we think will happen compared to what actually happens? After studying the results of the test of change, the final step is to act on the rapid cycle test. Decide what to do next. Test again with minor adjustments. Test under a different condition. Stop the test or implement the change. So, what are the options with a completed PDSA cycle? If the test showed some promise with manageable problems, modify the test accordingly. If you believe any problems arising during your test were situational, test under additional or different conditions. If it was a resounding success, implement the test. If you're quite pleased with the outcome, spread the test to other parts of your practice and repeat the test there. If the test was a bust, drop this idea and move on to your next test of change. If this happens, and it does, don't be discouraged. It is precisely for this reason that the test was of a small change, rapidly implemented. No harm done. Now, select one of your change ideas that you generated in an earlier exercise. Follow steps 1 to 4 using your workbook to document during the exercise. Please feel free to pause the video to focus on this exercise. PDSA rapid cycle tests of change must integrate into regular work activities in the practice. You have to designate the time, the place, and the people to accomplish the test. PDSA tests of change must be small enough that they are easy and practical. When working through a test of change, remember the ideas have to be feasible. Successful PDSA rapid cycles are small and quick. Faculty at IHI often say, "What can you do Tuesday by 2?" No one PDSA will change the world. A positive corollary to that may be that only iterative PDSAs will change healthcare, truly change it. So anticipate iterative cycles. Plan for future modifications and document using the PDSA worksheet because it really helps you. Innovate. Keep it small, keep it feasible, and keep it focused. PDSA cycles are small, repeated, iterative tests of change leading to improvement. In real life, this is often what PDSA cycles look like. The complexity of our healthcare system often precludes us from a linear pathway and takes us on this more convoluted journey with each test of change, increasing in complexity itself. Don't let this discourage you. Even in failure, we learn about our systems and can more effectively target our improvement efforts. In conclusion, we have reviewed each element of the model for improvement in the context of how a project is developed and completed. Review the flow: project idea, problem statement, aim, measures, change ideas, and testing of several changes via the PDSA cycle. We use a project charter as a work plan and communication document for our QI projects. Remember that you will generate many change ideas and perform several tests of change, or PDSA cycles, for each change idea. Now you are able to prepare your improvement charter, develop your problem statement, establish an aim statement, define measures relating to your aim, construct a driver diagram for your project, develop change ideas, and use the PDSA cycle to test change ideas. Please contact faculty at your site for any questions.